Welcome to this CTSNet Google Hangout. My name's Joel Dunning, and I'm very delighted to be here with two outstanding practitioners in our field. I have Atiq Rehman, Director of Minimally Invasive Cardiac Surgery from Sarasota, and I have Kamran Baig, Associate Professor of Cardiology from the University of Nottingham. Now, the reason we're having this Google Hangout is because they have both performed a very significant event. They have both performed the very first transcatheter aortic valve replacement in Pakistan, and that's what we're going to talk about. So, first of all, if I turn to you, Atiq, how did this come about? You're a surgeon from the US. How did you come to pair up with Kamran to perform the first TAVR in Pakistan?
Joel, if you may recall, I was able to help those guys start their first minimally invasive cardiac surgery program in 2013. We had planned to do 6-month increments. The first instance, we went ahead with minimally invasive mitrals. 6 months later, we came with mini AVRs. And then the next step was to do minimally invasive coronary bypass. And the timing in the interim, if you see, the transcatheter valve has been commercialized for the last 3 to 4 years. And I thought instead of going for coronaries, we need to go ahead and stress for the transcatheter valve therapy. So that's how I, convinced those guys to proceed with that. And I think the team was ready at this time, so that's how it came into being.
And Kamran Baig, welcome to the Google Hangout. You were, I believe, the official proctor for this, and how was it going to a very sort of different country to where you normally perform this, and starting off a brand new team in a country that certainly isn't the same as sunny Nottingham?
Thank you very much, Joel. Well, yes, you're right. Every new country has its own challenges and has its own limitations, as well as its own advantages. And Pakistan was no different. Obviously, the Western world has benefited from the availability of the TAVR treatment over at least the last 6 to 7 years percutaneously, and the procedure and the prosthesis become refined to a point where most experienced centres and practitioners in the Western world are pretty good at the procedure. When you arrive in a new environment where perhaps the experience and the resources and the skill mix are very different to what we might traditionally expect in the Western world, there is a very steep part of the learning curve to be negotiated in a very short period of time. And Pakistan was no different to any other country in that regard when we arrived.
Thank you. And Atiq, so you were both overseas trying to train a centre prior to coming to a new procedure. I mean, how did you achieve overseas proctoring, and then how did you sort of turn up on the day to do a brand new procedure? Because there might be people out there thinking about doing the same. How did that go, Atiq?
Yeah, I think overseas experience mine for transcatheter valve therapy is quite limited. I would say Kamran has probably done more than me for sure overseas, but being a U.S. proctor, I knew what the guidelines were for transcatheter valve therapy, pre-training. So worked with them for at least one and a half months to get them to do what the steps will be, what guide wires, what catheters, and what all those things they need, and line them up. And then, of course, went over with them some videos and the cases they wanted to perform them on that day. And I guess we'll talk more about it, but eventually it was the day of the surgery when we reviewed those cases. Kamran was there and I was there, and when we reviewed those cases and picked up those cases which were appropriate for the first transcatheter valve.
Maybe Atiq, also maybe tell us where was this centre, what's its name, and how is it funded? What is the system out there in Pakistan that does it, for those who don't know?
Yeah, so this center is Armed Forces Institute of Cardiology, which is next to the capital in Rawalpindi, and they do around 2,000 hearts, and they do, I don't remember the exact number, but thousands of cats per year. I don't exactly honestly remember the number. It's a tremendous amount of number. They do maybe 80 to 100 cats per day. So they are very proficient with usual cardiology and cardiac surgery protocols and procedures. And I think this was the right time, right center to be picked up for this kind of a procedure.
And Kamran, for a proctor being sent out and turning up for the first time, what was the skill of the cardiologists and surgeons there? Did you feel they had a very good level of knowledge, just for sort of just in case someone's about to set off and do something similar?
Well, it's interesting. My experience around the world has taught me that actually, if you're parachuted into a cath lab, and I would presume that being parachuted into a cardiac theatre would be no different, in pretty much any established centre in the world, and you are asked to open your eyes, you probably have difficulty in identifying exactly which country you are in, because the world is so internationalised and commoditised. So on that basis, the cardiologists and the cardiac surgeons that I met, that were the local people, were pretty much up to speed with what we would normally know and practice in Western centres, not least because the vast majority are trained in the West at some stage of their career, and then of course they transfer the experience of their technology back to their home centre. So where they had to learn and make the leap was really in adopting the specifics of the new procedure, which of course are a change from back practice and sometimes require leaps of faith, which if you're not supported are difficult to take, and that's really where the proctor comes in to supporting them.
Maybe Kamran as well, just maybe tell us a little bit about the case you did. What was the case and how did it go?
Well, as Atiq was saying a moment ago, in advance of the actual visit to deliver the cases, we had pre-screened 5 patients with aortic stenosis that were relatively elderly that they had identified, and we'd sort of red, amber, green rated them as high risk or slightly less high risk. And so what we look to do generally for new centres is to try and impose a sort of pattern of practice that we would expect to follow in the West. So, for example, we would have an MDT process at the outset, we would reevaluate the data, we would gain multidisciplinary opinion, and then we'd case select. And we did nothing different when we arrived in Royal Pindi. The first day started with a 2 to 3 hour MDT with all involved parties, and we finally selected a case. It was a case that we deemed to be, led by me I suspect, probably the least risky and perhaps the most straightforward. And that was an 87-year-old gentleman with severe aortic stenosis, reasonably good left ventricle, and reasonably good renal function, and reasonably slim. So we had all parameters as far as we could optimize them in our favor for a first case.
And Atiq, from your point of view, how did that case go? How long did it take, and how long did that patient stay in hospital?
The case went actually very smoothly. It was, I would say, as routine as it can get for the first case. If I remember correctly, I think it was 90 minutes from start to skin, I would say. And it went pretty smoothly. I mean, there was no big hitches there. And the patient stayed in the hospital for, I think, 4 to 5 days, and was discharged, and actually was sitting up and walking, next morning. So as we expected. I think you could start programs anywhere if you have, I would say, done some homework and you have worked with those programs in advance. As Kamran said, that most of the time you're parachuted as a proctor. That's a bit difficult, and that happens to me every time when you're in the US or he's in the UK. But this program, the only thing is I did work with those guys in advance. But still, there are surprises when you get there, So at the end of the day, it was very smooth and it went very well.
So I suppose the reason we're having this conversation is because TAVR, it's established in the Western world, but in developing countries, what will the future be in developing countries? It's expensive, it's very high technology. Do you think this will spread, or will this still just be the preserve of the richest 3%? Atiq.
Okay, so I'll answer. Okay, that's fine. Basically, you see, I agree. I mean, this is a very pertinent question or critique. I would say that it's a very high-end technology. It's expensive, and we're trying to use it in emerging markets. I think, unfortunately, in these countries, you do have discrepancy between the different classes of the society. But having said that, we can't change the reality. At the same time, there's a drain of patients going out of these countries. So if they have the technological expertise and clinical expertise, I think they need to be able to retain those patients in those countries. So I don't think this will be commonplace for everyone in those countries, but certain population should be able to benefit from it, and they will not be leaving the country going abroad for the same thing.
And I suppose finally, Kamran, as a proctor who goes out to many countries, do you have any advice for anybody else considering proctoring in a developing country? Is it different to doing it in Europe?
It is significantly different only because you have to account for the background difference in resources and approach and attitude. Of course, one needs to be all-encompassing to all parties and generally supportive rather than not. But it's something that is very rewarding because, of course, you're involved in transferring a technology and a skill base which is only going to spread. And I can think of several countries where I've contributed to lighting the blue touch paper, so as to speak, for the TAVR program. And when I look back at them 2 or 3 years later, it's widespread across the country with excellent results. And so it can only be for the benefit of all the people who get involved and receive the treatment that people are asked to support new countries if they are travelling distance away or there's a lot of difficulty involved in bringing them up to speed, that it's a worthwhile exercise.
Well, it's been fascinating talking to you both. I suppose from us and the whole community worldwide, we should really congratulate you both for this world first in Pakistan. And as you've said, starting a whole country on a brand new procedure is a pretty unique experience and one that only very few people achieve. So both Atiq and Kamran, very well indeed for doing that. So myself, Joel Dunning at CTSNet, and everyone here, can I just say to both of you, thank you very much for joining us today for this Google Hangout.
Thank you very much, Joel.